Good afternoon. Welcome you all to these deep dive sessions, and mostly this will be a case presentations and it will be an interactive discussions. Each year we do from our uro-oncological team to present some interesting cases and an interactive discussions. Last 2 years we have discussed bladder cancers, urinary upper tract TCC as well as prostate cancers. But this year's I chosen a topic.
Sorry, we cannot hear you clearly.
This year we will be discussing on something different: kidney cancers, kidney tumor or mass. So this year I'm just delighted to know that Professor S.A. Khan, Fakhrul Islam, as well as I think Professor Fakhrul Islam is not here, and as well as you all know, Dr. Jamal Qadir, Dr. Najim Parvez, Tanweek Jong, as well as Professor Said Akram Hussain, and all of you know that they are very much well known to us about their own field. So just I start my topics. Right, we are talking about first Mr. M.S.S. It's a short name, a 59-year gentleman presented with incidental findings of right renal mass in ultrasound scan in routine checkup. He don't have any hematuria, no weight loss, recent dry cough, hypertension, non-hypertension for a long time with well controlled, diabetes and with normal renal function. He went for a just routine checkup and found a large mass about in the ultrasound scan. You can see that 97 millimeter into 77 millimeter, and he denies that he don't have any problem at all. He is surprised to see what is going on. So my question to Professor S.A. Khan, that he found these things and he come to you, because normally at this stage patients come to urologist by some referral, and what do you do? We see this different opinion of sending the request. Some people says CT scan of the whole abdomen. Some people the CT scan of the abdomen and chest, and MRI of the whole abdomen, or when we will request for MRI. These are the questions we face number. It is not my case because the case came to me later on, so he has already done some of the tests. So if you are in a position, so what test you will prescribe him? Seeing an ultrasound scan.
Yes, ultrasound scan showed there is a renal tumor. For evaluation of the renal tumor, best imaging study is a multi-phase contrast study. I mean the CT scan. That will tell the details about the tumor extension and everything. The CT, contrast CT or CT urogram, or there is option 3 option only. In that case, contrast CT scan of the abdomen, including the kidney, and the chest CT scan.
So we will request a contrast CT scan of the whole abdomen and chest.
Chest.
Not whole abdomen.
Definitely.
Not whole abdomen. Why we will do that? I mean, why don't the abdomen? Why you are asking for chest?
So actually we need to, actually for evaluation of the kidney, the radiologist protocol is the CT urogram, contrast CT urogram. And with that contrast, he detect the primary lesion as well as other lesion. When he feels any sort of, when he sees any doubt about the metastasis other places, he can include other additional images. And it is a very weak tumor. there is every chance of hematogenous metastasis to the lung. And this is the guideline recommendation is the contrast study of the kidney as well as the study of the chest is mandatory.
And if it is a T1A tumor, would you do that?
Sorry?
There is a smaller tumor, say for example only 5 centimeter mass, something like that. Would you do the chest and abdomen or just the abdomen?
There is, according to the study report, there is minimum chance, very small tumor, there is minimum chance of metastasis. In that case, one can avoid the CT scan of the chest. But you must do the
Thank you.
contrast study of the kidney.
Dr. Jamal Kadir, do you have any comment on that?
Two comments. The first one, it's clearly by the ultrasound that there is a mass 9 in 7 cm. And probably in the prostate, the size is a bit, according to his age, is relatively young. It's a bit, I think it was almost 40 cc and with some heterogeneous area there. So what I'll do, I'll start with the CT contrast, CT chest and abdomen. And I may do just simple PR exam and PSA just to rule out any incidental findings in the prostate.
Okay, thank you. So move on to that. He had only CT whole abdomen, actually requested by one of our urologists. So he has done, but this is a very messy lot of films. So I just take a comment from the radiologist that mass type is a mixed cystic and solid. Macroscopic fat is nothing there. Solid enhancement, yes. Axial entry posterior, mostly posterior. Craniocaudal location, interpolar or lower polar. Mass margin is circumcised, and capsular locations greater than 50% exophytic, distance from the sinus or Kalachny system involving the sinus fat, tumor thrombus, no thrombus, lymph node, multiple subcentric and paracaval lymph nodes, para-aortic and paracaval lymph nodes, largest one was 8 millimeter. Metastasis in the field, in the abdominal film, whatever the cyst is available, they present in the right adrenal gland as well as in the left lung lower lobe. So we got a patient with suspected metastasis in the right adrenal gland, but there is no continuity. It is a little bit lower pole mass, but we can see the metastasis you can see in the adrenal gland. So may I request Dr. Nadim Parvez, how you stage this disease at this stage? Do you want to do something more, or you have enough evidence?
Sorry, actually, I didn't hear the question clearly.
The thing is that you are happy with this. Do you do anything more for defining the metastasis, or?
No, I think we have done enough staging for prostate, as Dr. Jamal Hader says, and then for the other doctors also for the staging. So we have enough staging. First, we need to know what it is actually, the lesion itself.
How you describe the adrenal metastasis? Is it adrenal metastasis that is not continuous of the kidney?
If the chest is not done, I would do the chest scan as well. But that's the only thing.
What type of chest scan you will do? I mean, what is the HSCT or contrast CT?
I would prefer the CT scan, CT thorax, because the X-ray is a simple one, but X-ray is not showing everything. So CT scan of the chest.
HRCT?
Yes.
All right. So that question is whether HSCT or contrast CT, whole body MRI, FDG PET scan of the brain, or bone scans. Do you do anything more, like PET scan?
I think it's, in my view, everything is done almost, so first we need to establish what it is. PET scan will be, we want to see the metabolic, but we want to see a bit later, not at this stage. I think we need some tissue or histology for this.
All right. So he had a HSCT scan of the chest, and he described that there is no definite SOL metastatic nodules in the lung parenchyma. So, and other bony thorax and other things are normal. So, what do you do now?
Lung is clear here? Clear. No lung metastasis,
Lung
is clear.
metastasis. According to HRCT, not a contrast CT. He done a HRCT, non-contrast CT. Yes, please. Can I have a microphone there? So HRCT is a compromised person, you said, want to say. So what do you do? I mean, now you have already had a CT scan now, and you will send again to repeat the CT scan with the contrast, or you will do anything more?
Well, I think we should go for a contrast CT. That is cheaper as well as more useful.
Anybody differ with the situations? Do you want to do contrast
Actually,
CT repeat?
this seems to be a fit patient and renal function test is good or relatively there is no any impairment. So to go for the, as a staging, after the ultrasound, immediately to go with the contrast CT chest and abdomen.
Contrast CT is enough. Okay. So if we see that there is an abdominal flame, chest metastasis, and then if somebody comes to you, so we'll do again contrast CT. Any brain or bone scan at this stage? Do you need any bone scan? You will look at for bone scan. Even if you got a lung mass, you need a bone scan. Or if there is no symptom in the bone, do you do bone scan even? Dr. Tanwi Chong, will you suggest anything?
To be very honest, in our practice, we don't routinely do bone scans or PET scans. I actually agree with everyone here that a contrast CT of at least the thorax and the abdomen would probably be optimal. The problem with PET scans and bone scans, I think, in RCCs is that sometimes there can be differing levels of avidity. RCCs, in our experience, is one of those things whereby they may enhance, there may be variable enhancement with nuclear medicine scans, so it's not always useful. When it lights up, it's useful. When it doesn't, it's hard to tell sometimes. And I think that's why most guidelines would basically mandate that we just do CT scans, at least with contrast for staging. Yeah.
All right. So, however, as you can discuss this one, so do you need a PET CT scan? Everybody know, but he had done. So, what EU guidelines says about it? Use of multi-phasic contrast enhanced computed tomography of the abdomen and chest for the diagnosis of estrogen renal tumor. Omits chest CT in patient with incidentally noted CT1A disease due to low risk of lung metastasis in the cohort. We discussed that. Use of magnetic resonance imaging is better to evaluate the venous involvement, reduce radiation, or avoid intravenous contrast medium. Non-ionizing modalities like MRI or contrast-enhanced ultrasound for further characteristics of a small renal mass, or tumor thrombus, or differentiation of unclear renal masses in case the results of contrast-enhanced CT is indeterminate. Offer brain CT or MRI in metastatic patients when systemic therapy or cytoreactive nephrectomy is considered. Do not routinely use bone scan or positive PET CT scan for staging renal cell carcinoma. So this is the guideline. We just recollect all these things, and we have already all discussed. This is for the resident and the junior urologist. So he had a bone scan. PET CT scan done, however. And I think you can see probably the letters a little bit. The large FDG avid exophytic mixed density mass in the lower and lateral aspect of the right kidney, SUV max 7.2, suggesting malignant lesions, low avid subpleural nodules, SUV max 1.3 in the posterior aspect of the upper lobe of the right lung and posterior basal segment of the lower lobe of the left side. SUV max is 1.4. FDG, soft tissue nodules in the right adrenal gland, 2.1 SUV max, suggesting metastatic lesions. No other suspicious masses of abdominal FDG uptake elsewhere in the body. So we have some low uptake of FDG in both lungs field, 1.4 and 1.3, but adrenal gland is a little bit high uptake as well as the, the main lesion is very much high. So in these low uptake lesions, do you consider it as a malignant or what do you say?
Now, as we understood, the CT scan of the chest was negative, right? And for one reason or the other, this patient did PET scan, which is, in our daily practice, as my colleague said, it's not a standard of care to do PET scan for each and every patient with RCC, unless radiologically there is some equivocal findings. Anyhow, so the patient did the PET scan, and now we're talking about 2 lesions, right, in both lungs, and the SUV is high or low?
SUV 1.31, 1.41.
1 point something, and well, this to me it's normal. I mean, this is maybe unless it is high, but CT scan is normal, and the PET scan, these 2 lesion is the SUV is low. To me, I would consider just close observation rather than to label this patient as metastatic from this point.
Now, one thing is that CT scan is one CT scan, which is a part of the abdominal CT. That was abnormal. That shows the 2 nodules. And the next CT scan was non-contrast.
The other CT chest showed
yeah.
it was there, the lesions were there.
And one film with the contrast. And now, in the abdominal film, abdominal CT scan, when it was done with the contrast, then it was visible. When the HRCT film was done without contrast, then it was not visible.
But still now, since the PET scan was done, and it's only 1 point something, the SUV, to me, difficult really to label this patient metastatic at this point. Probably I just keep in close observation for this patient for the lung.
Right. So what do you, Professor Khan, what do you do with the main lesion now? Because
I totally agree. Yeah, I totally agree with Jamal. I think the lung lesions look to me like they are strictly indeterminate. Low PET avidity, small, less than 1 cm, likely, even beyond the resolution of either PET or the CT. And I think the key here is that we've got a large renal lesion that requires management, and the lung can easily wait and observe. The caveat being that the lung could be tumor, it could not be tumor. If it is, it will declare itself, and subsequently the patient can still be treated after that if the lung proves itself to be malignant as well.
So what do we do then with the kidney? Do you do anything for the kidney now, Professor Khan?
Yeah, that's a good question. So, really interesting case. What do we do with the kidney?
Leave it behind. Then after 3-4 months, if the metastasis increases, then what will do then?
Yeah, I think the big question here is whether we should go for just a nephrectomy if it's suspicious enough, versus whether we should, get a biopsy first. So I think it depends on the radiological appearance. I think my urology colleagues usually, handle this. And if the lesion is suspicious enough, which it sounds like it is from the scan description, we might just go for a nephrectomy. Yeah.
Right. So what do you do? Do you do biopsy before that?
I totally agree with my colleague. I mean, not each and every suspected RCC to go for biopsy. It's within a multidisciplinary with your radiologist, you can see, and urologist, you can see the lesion. If this type of lesion, probably will go for surgery without, assuming that most probably it is RCC. Or at least renal cancer.
Anything? Any differing?
I like to mention few controversies regarding the PET scan and the core biopsy of the kidney. Practical problem. I think everybody faces this problem. When PET scan is available, patient usually become afraid, and they know browsing the internet, the PET scan is the scan which can tell all the cancer, whether there is any metastasis. So with the pressure of the patient or with, by the suggestion of the physician, almost each and every patient do the PET scan. And many of the PET scan result comes with this, with simple inflammation. Even after, we face this problem after surgery. Immediately after surgery, they go for the PET scan, and PET scan says there is a FDG, a bit lesion in the region of the kidney. And I did this surgery, I know whether there is any chance of residual tumor or recurrence within very short time. I'm sure there is no. So this creates a problem. Even this lung is his age is 59. There may be inflammatory lesion. That there may be little bit of FDG uptake is there, metabolic uptake may be there. That may create a problem. So again, I should suggest everyone to go with the guideline. Never go beyond guideline. What guideline says? Guideline recommends only the contrast CT scan. And when there is no symptom, lesion is small, no need of doing the bone scan. In suspected cases, you can do the CT scan only. This is the American Urology Association guidelines. Yeah.
Okay.
And
Any?
Coming to the point, and in this case, I'll not do the biopsy straight away. I'll go for the radical nephrectomy because the large lesion, CT says there is solid and cystic lesion. What happens if anyone go for the true cut biopsy? The tissue come from the degenerated area. There is no malignant lesion. Can you say there is no malignancy? Again, you have to go for doing the either open biopsy or go for nephrectomy. Straight away, I'll go for the nephrectomy,
Right.
radical nephrectomy.
Okay. I mean, but if you go for systemic therapy, then probably you need a biopsy proof in case of, because you need to know whether it is chromophobe tumor or clear cell tumor or.
Yeah, I mean, if the decision is for systemic therapy, but this patient has what looks like early to locally advanced disease, so I think radical surgery is probably going to be a recommendation as long as the patient is fit. Yeah.
Thank you. So he had a core biopsy done in the clear cell carcinoma and nuclear gate 2 and oblique 4 all his organization good. So moderately differentiated. So EV guidelines for renal tumor biopsy: perform a renal biopsy before ablative or systemic therapy without performing or without previous histology. Perform a percutaneous biopsy in select patients who are considering active surveillance. Use a coaxial technique when performing a renal biopsy. Do not perform renal biopsy of cystic renal masses unless significant solid component visible at the imaging. Use a core biopsy technique rather than a fine needle aspiration for histological accreditation of solid renal tumors. Okay, so we probably discuss all these points. So would you do any genetic assessment for these patients before? This is not a routine practice, all right, but in case, I just want to know, you are practicing in advanced setup, so I need to know, would you do genetic assessments in a patients like this?
We do for young patients, according to these guidelines, we do routinely offer genetic testing. There are, I guess, a few very widely known genetic syndromes associated with RCCs, especially with clear cells. So certainly it mandates a discussion with the patient. Genetic testing in RCC is mainly for kind of family planning reasons. But generally we do offer to young patients with RCCs.
Thank you. So guideline says that perform a genetic evaluation in patient with age less than 46 with bilateral multifocal tumor or a patient or a first or second relative of RCC or a chosen blood relative with a known pathogenic variant and or a specific histological characteristics which suggest the presence of hereditary form of RCC. Refer patients to cancer genetics or to a comprehensive clinical care center in case of suspected hereditary carcinoma, renal cell carcinoma. So now in a position what to do next, whether we will do radical nephrectomy considering it as a non-metastatic RCC. So we agreed upon that. Regarding nephrectomy and considering it is a metastatic RCC, further we can do that. Tyrosine kinase inhibitor or immunotherapy, first to see the response of the metastatic lesions, 1 or 2 doses, and then go for cytoreductive chemotherapy. So which one is?
So I'll just comment about the first one, radical nephrectomy, considering it's non-metastatic. Maybe you're talking because of this patient, he should go for radical, but we have to keep in mind the location of the tumor, the size to consider partial, whether it is by laparoscopic, open, or by robotic even. And to me, it's still, I'm not that convinced that we have a metastatic disease. So in my opinion, to go for surgery.
All right. Anybody any differ further from the audience? So we have come to the point of this patient, of this patient. So we need to decide what. So Professor Salam, we want to differ it anything way? If you agree with this, it's fine.
Systemic therapy would be appropriate in these particular cases, and maybe after 12 weeks or 3 months, maybe you can do a partial nephrectomy. It is very much feasible in this particular case with open or...
But he has got adrenal metastasis. So how will you do the partial nephrectomy?
So in adrenal metastasis, in that case, of course, radical nephrectomy would be, or complete clearance of the mass as a cytoreductive surgery would be more appropriate. Okay, we agree with that, but before that, the immunotherapy and the TKI therapy should be given for 3 months.
Okay.
I have a comment with my due respect to Dr. Salam. Now, it seems to be, and maybe urologists can correct me if I'm wrong, that the tumor is, the location and the size is close to the hilum, so it's really difficult to do partial, which we hope to do wherever we can and whenever we can. But it seems to be here is, invading the hilum. So whether patients will receive systemic or will not receive, probably that will not change the fact that he will go for nephrectomy. I don't think so in these patients without any very convincing scenario of having metastatic to go for systemic first. If he's fit and he's young and it seems to be he's fit to go for surgery straight away.
All right. And is there any consideration for metastatectomy as well as the radical nephrectomy? But only two metastases.
No, but no cytoreduction nephrectomy, because if we agree that this is non-metastatic, it's non-metastatic. You get as if you are, diagnosed patient with the RCC and you go for surgery.
Okay. Thank you. So we are finished with this case. And last of all, do you actually practice any prognostic models for metastatic or non-metastatic cases before giving you systemic therapy or Dr. Khan? Any prognostic model you follow?
I personally use IMDC because IMDC was basically developed in the era of TKIs, whereas MSKCC is an older prognostic model that was developed in the era of interferons. But the key to note here is that these prognostic models are actually for metastatic or advanced disease. So I will be very careful about applying them to the setting of a locally advanced or early tumor. Certainly if, say, this patient has what appears to be an early stage tumor, but the IMDC risk score is off the charts or is high, then there might be some suspicion that the clinical features are not in keeping with the radiological features. But in early stage, I think generally these prognostic models have limited utility. But I do use IMDC a lot for advanced cancer.
All right. So thank you very much. So I have finished with this case. If you have any want to discuss another one, so here's a UA guideline for first-line treatment of metastatic RCC, as you all know, and standard of care. So as it not considering as a metastatic disease, so we skip that one. Thank you very much. So case 2, we have 14 minutes to go, so we'll be running it a little bit faster. So he's a 53 years of obese male patient, about 117 kg weight. He had a discomfort in the right loin, and he had a CT scan. But in fact, when I inquired the things, I found a previous CT scan about 2 years ago, and almost similar picture. But the CT scan was from the periphery of the country, and that was not, the comment was not there whether what was a Bosniak or not. But the new CT scan shows it's a right renal cyst, and reported as that, you can see that complex cystic mass lesion in the right kidney, Bosniak type 3, distorted, displaced collective systems, and is moderately dilated lower myotic calyces. There is small calculus in the left kidneys, normally excreting both kidneys. The mass was very big. It was, I am forget to mention about the size, was about 18 centimeter. It's a big mass. And he is quite comfortably moving. Recently he has got some discomfort. So what to do now? So Bosniak 3, cystic mass, and it's a huge mass. So what, should we go for any other scan or go directly to something what we want to do?
Any new CT scan or any radiological
This
study?
CT scan is new. That cases that is a complex cystic mass. The previous CT scan did not comment on the Bosniak type, but it was size was same. That was about 3 to 4 years ago, and the size was exactly the same, 18 centimeter, and now is 18 or 1.1 centimeter. This is there for 3 years. So shall we?
How is his other kidney? How the condition?
Other kidney is fine.
Fine, not quite normal.
No, no problem.
He is 57 years, I think.
57 years.
57 years, was obese. And
And is a duplex collecting system on the
And-
right side.
how is the rest of the kidney other than the cyst? The almost whole of the kidney is involved by the cyst.
But
And
very
the
thin
feature is
amount,
almost-
thin kidney. You can see here. You can see in this scenario. Sorry, here a rim of kidney tissue is there.
Yes.
We do not have any, split renal function test, but we can see that some contrast is there, and so
Here, I think radiological opinion is very important.
so would you
may be
happy with that?
It
Would
may
you
be
happy-
simple hydronephrotic kidney with the normal contrast enhance the peripheral rim of the normal kidney. There is no nodularity or localized thickening in this image. So radiologist expert opinion here is very important.
He said
For-
that this is a Bosniak
For
3.
Bosniak 3, there is definitely one of the important differential diagnoses is the hydronephrotic kidney, because there is no lesion in and around the kidney.
Dr. Jamal, do you have any comment on that?
Yeah, actually,
Do you
if
go
it
for
is
any
the-
other scan or just happy with this?
No, this is a new one. You said this is a new one, right? And it is exactly like the one which was done 2 to 3 years ago. So in my opinion, probably we are not dealing with a cancer in the kidney or RCC, because 2 or 3 years it will not be the same. And so either it's like the differential diagnosis in this patient, maybe it's a large cyst there, or maybe it's a Kesselman disease. So does the patient have any symptoms, or just this is like
recent
incidental
discomfort.
finding?
Recent discomfort.
Yeah.
Discomfort
So I think
only.
the urologist may have to say about this, whether he can just resect it for at least to relieve the symptoms.
Right. But he was very much inquisitive. He moves from place to place. So somebody with this anxious mind, he done a MRI scan, MRI rugam, and that was also reported as Bosniak 3. MRI scan, some solid amount of tissue inside the cyst, they found that it can be reported as. So, do you need a tissue diagnosis or anything on this matter? Or you will go directly for the surgery?
This is very difficult for every urologist, If
That's why here for.
if this patient comes with the previous only first CT scan and very difficult, and again he come with the MRI urogram that shows that radiologist says there is a solid mass. So important expert
You can say that.
radiologist opinion is necessary. If he says there is a solid lesion inside, definitely there is high chance of either Bosniak 3 or Bosniak 4. In that case, if it is Bosniak 3, really Bosniak 3, with a huge hydronephrosis, I will not go for any sort of true cut or aspiration biopsy. There is every chances of spillage, and no guidelines says initial without special situation recommended for the biopsy.
All right.
And straight away I will discuss with the patient condition, the Bosniak 3 and probability of the malignancy 40 to 60% in Bosniak 3.
50%.
There is probability of malignancy 40 to 60%. And Bosniak 4, it is more than 80%. So in that case, both the cases, I will discuss with the patient and I will straightforward go for the huge hydronephrotic kidney with thin cortex, straight away go for radical surgery and doing biopsy after that.
Okay, then if the radical surgery, what will do? You will do nephrectomy.
Yeah.
And then if there comes a benign, then what will
And
do?
before that, I will discuss, before that I will do the, I will confirm the normal function of opposite kidney. And again I will see the urinary protein among
No,
the
but
urinary
patient
protein.
can say afterwards that why you do the nephrectomy.
I will
in-
discuss
I
it,
mean,
it can be benign, there is gross hydronephrosis, there is chance, the chance 60% and 40% chance may be benign. And you have to decide.
Right. So what happened? So here in the UA guidelines, it says that you can do MRI because it's more sensitive for the cystic lesion evaluation. And they in 2019 they actually actually describes the guideline and comparing the both MRI and CT finding of Bosniak's cyst classifications. And there's even a confusion, as you saw in the last year, that you can do a MRI of the lesion. So we have discussed that. And now, one of our colleague, they done a cyst aspiration and biopsy. Sent for the aspiration cytology, and then cyst was you can see the needle in the middle of the cyst, and he aspirated the things, and he did the cytology of the aspirated fluid, and that comes out nothing. That was normal, just a simple cyst. So it is not recommended in the guideline that they said, sorry, they said actually you have to take the biopsy from the UV guideline says if you take the biopsy need to be taken, then you have to take from the solid part, like a core biopsy. But aspiration biopsy is not recommended. So now that aspiration was negative, and patient says that I don't have any cancer. That's why you want to do operation. So whether we will do repeat biopsy from the solid part, laparoscopic decoordination and biopsy, partial nephrectomy, open surgery, what you will do?
This is the dilemma created by the physician himself with a big large cyst, and expert any urologist can say there is more than 50% chances of coming negative result.
This is not the
no
patient does not know the guideline. He is in front of
no
me,
negative cell.
and he was asking me.
Even a guideline says when you recommend FNAC or aspiration biopsy or true cut biopsy for the case of the cyst, before recommending it, you must discuss with the patient how much chances of, how percentage chances of coming test as a negative. And after that, you cannot exclude malignancy. Again, you have to go.
According to guideline, the biopsy was not correct way to do it. So can we do a repeat biopsy, Dr. Nadim? Dr. Nadim Parvez, should we go for a repeat biopsy? Yes. Yeah, of course, why not? We have enough time.
my
patients. One patient
My-
from I got cyst carcinoma. This sort of cyst and giving cancer. Second patient, my friend, who gave me the similar cyst, he has RCC of the tumor. So rare thing can also happen. This is my experience.
So I agree with this comment actually. I would be going in that line.
Can you repeat it?
I agree that, I will go for a partial surgery for this patient to have that tissue established. Like it says, but can be cancer in there as well.
Right. So, which way will do the surgery? Anybody from audience? Professor Khan, what? It is laparoscopic decortication or partial nephrectomy, laparoscopically or open? Because can you?
It can be done both laparoscopy and or open. It is the surgeon choice.
Yes,
Now-
but if available, I will go for lab.
It's 117 kg.
117 kg.
So
So one thing-
if available, I will go for lab. But if not available, like it's a surgeon choice, but if available both options, then lab can be the one which I would suggest.
Is there any chance of spillage of the cyst?
Yeah,
No.
the-
During surgery, there is no chance of if the surgeon takes the precautionary measure, there is less chance, minimum chance of spillage. The image shows what General Harun says. Most likely this is cystic RCC or the cancer in the cyst, definitely. The radiological feature almost says. In that case, straight away, even second biopsy may comes negative. Third biopsy may comes negative because huge cyst and CT guided needle placement and maybe in other places there is huge hematoma in the kidney. So after counseling, it is better to go for the nephrectomy and biopsy later on the histopathology.
All right.
Radical.
Anybody in the audience contradict with this, with the comment? So you are for open partial nephrectomy.
Open partial nephrectomy would be
Yes,
a reasonable solution.
Oh, there is no symptom of hydatid cyst or anything like that. Okay, and do you take a frozen section during surgery? Will take? No, man, what will do? All right. Will it be any help if you do frozen sections? Dr. Nozul, just one minute.
Frozen section, yes.
Okay, thank you.
If you take biopsy, open biopsy, representative biopsy, that will break your oncological principle. Definitely,
Okay,
there
that's
is
fine.
chances of spillage.
Okay.
Sir, this is a very huge cyst, very big cyst, and very minimum kidney tissue is present here as per CT scan. So radiological report is very important as per Professor Sekhan says. We can take the review from the other expert radiologist. If he says there's a Bosniak, definitely if it comes to Bosniak 3,
Yes.
and we can counsel the patient about the probability of the cancer or malignancy, then we can go for a straightforward nephrectomy. There is no chance to do the
Okay.
partial or any decortication of this.
Okay, thank you. Ladies and gentlemen, it's a wonderful evening or afternoon with you, and we have discussed two cases, very important day-to-day practice. I think the decision definitely lies on the surgeon's choice as well as surgeon's experience as well as, and the route is also depends on the expertise of the surgeon. I think we have, I also learned a lot. I think everybody have benefited, particularly the juniors and trainee. And I again thank our panelists to actively part, and everybody actually acted very actively in these discussions. And I again thank you everybody to join the sessions. Thank you all. See you next year.